Good afternoon, everyone. On behalf of the British Liver Trust, I'd like to thank you for joining us today and welcome you to the latest in our series of webinars. I can see we've still got plenty of people joining us at the moment, so I'll just run through some of the introductory points while others are still logging on. For today, we'll be focusing our webinar on liver cancer. Liver cancer is an issue of huge importance. Liver cancer rates have more than doubled in 30 years. And every year, 6,000 people are diagnosed with liver cancer in the UK. In the UK, primary liver cancer has been amongst the cancers with the most rapid rate of growth in both incidence and mortality over recent decades. And it's projected to be the cancer with the highest average annual increase in rates over the next 15 years. So we know it's a topic of huge significance. The British Liver Trust team works as part of a number of initiatives to raise the profile of liver cancer. And we also provide support and information to patients through fact sheets, through publications, our specialist nurse helpline and our peer support groups. And this work is taking place day in, day out, but we chose the month of October to stage this particular webinar because October is designated as Liver Cancer Awareness Month. And it's a vital chance to raise funds and awareness and improve the early detection of liver cancer, as well as showing our support for people who are affected by liver cancer and their loved ones. We're joined today by an absolutely fantastic panel of speakers, and I'd like to take the opportunity to thank them for being here to talk to us all today. I'm delighted that we're joined by Dr. Rohini Sharma, a medical oncologist and clinical pharmacologist at Imperial College London, Dr. Abid Suddle, who's a consultant hepatologist at King's, Sarah Selimani, who's HCC lead nurse at King's, and Monica Walsh, who is here to share her story from the all-important patient perspective. So first up, I'm delighted to hand over to Dr. Rohini Sharma and Dr. Abid Suddle.
It's an absolute pleasure to be with you all this afternoon. My name is Abid Suddle. I'm a consultant hepatologist at King's College Hospital, and much of my practice is in the management of patients with primary liver cancer. Rohini, I don't know if you want to introduce yourself now?
Yeah, thanks, Abid. So yeah, my name's Rohini Sharma. I'm a medical oncologist and I'm the clinical and research lead for primary liver cancer at Imperial College.
So the first topic we're going to address today is who is at risk for liver cancer and who should be undergoing surveillance. And I think these are really important topics because we have really good treatments for liver cancer. It's about identifying people at the right stage. So liver cancer can be primary or secondary. Primary means that it's derived from within the liver. Secondary means that it's spread from other organs. We're going to concentrate on primary liver cancer. And there are two major subtypes. Hepatocellular carcinoma, or HCC, is the most common type, and it's a cancer that results from the liver cells. Cholangiocarcinoma is the less common type and tends to derive from the cells that line the bile ducts, which are a system of tubes within the liver. We'll be talking mainly about the most common type of primary liver cancer, which is hepatocellular carcinoma. You'll hear it abbreviated to HCC, and an older term that was used was hepatoma. In the vast majority of cases, in more than 90% of patients in the United Kingdom, HCC occurs in the context of chronic liver disease or cirrhosis. So the vast majority of people who will develop this cancer have an underlying risk factor, which is usually long-standing liver disease. Now, in the public's perception, this concept of chronic liver disease or cirrhosis is synonymous with alcohol, but actually that couldn't be further from the truth. There are many causes for liver disease and cirrhosis, and many which have absolutely nothing to do with alcohol. In the Western world, we will find that non-alcoholic fatty liver disease will become the #1 cause for liver problems within the near future. And this is the liver disease that results from diabetes, being overweight, having high blood pressure. These are all conditions which are extremely common. The difficulty from our perspective is that liver disease and cirrhosis can develop silently. They can develop without a particular person having any symptoms, and sometimes without there being an appreciable abnormality in blood tests that their general practitioner may be checking for other reasons. So early identification of liver disease is crucial, especially those who are developing the types that can cause scarring of the liver. But essentially what happens in cirrhosis is that the liver is damaged by something over a long period of time. This leads to the development of inflammation, scarring, and a change in the structure of the liver. So long-standing damage to the liver is the context in which these cancers develop in the vast majority of cases. So in terms of surveillance, what do we mean by surveillance? So surveillance, we perform surveillance when we know that there is a risk for a particular disease, a risk factor for a particular disease. We identify patients with that risk factor. We perform an investigation with the aim to diagnose the cancer at an early stage so that we can provide effective treatments. And all patients with underlying cirrhosis should be undergoing surveillance for liver cancer. The most important surveillance test is an ultrasound scan, which should be performed every 6 months. In addition to the ultrasound scan, sometimes we perform a blood test called alpha-fetoprotein, which is a blood test which is elevated in some patients with liver cancer, but only 60% of patients at an early stage. So alpha-fetoprotein on its own is not enough in terms of an effective surveillance method. In certain groups of patients who don't have cirrhosis, there is also a risk for developing liver cancer, and we'll also recommend that they undergo the ultrasound scan every 6 months. These are mainly people with hepatitis B infection who haven't developed cirrhosis as yet. And these patients should also undergo the surveillance program. The tragedy is when people develop liver cancer without having been diagnosed with cirrhosis. And if the diagnosis is made because of symptoms as a consequence of the cancer, often it's at a more advanced stage where we may still have treatments, but not the full range of treatment options we would have available if it was diagnosed at an earlier stage. And this is reflected in the fact that despite the fact that we know about the risk factors for the development of cancer, unfortunately 30% of people are diagnosed not during a planned surveillance program, but when they present to the emergency department with symptoms as a result of the cancer. So this moves me on to the second topic that we're going to discuss, and that is what to expect at diagnosis. What kind of investigations will you be having? And this partly depends on how the cancer has been diagnosed. We hope that the cancer is diagnosed when an abnormality is found on your ultrasound scan. So the aim of doing the ultrasound scan is to see if there's any change, and in specific, if there is a development of a new nodule or lump or abnormality within the liver. On its own, the ultrasound is not enough to diagnose cancer, and you will need further investigations, which will usually include a CT scan or an MRI scan with contrast. Contrast is something which is injected into your vein and helps us look at the nodule in some detail, or the abnormality in some detail, in order to understand whether it is a cancer or not. In the majority of patients who have underlying cirrhosis, we are able to make a diagnosis without the requirement for a liver biopsy. But increasingly, we are performing a biopsy to both confirm the diagnosis and to also provide further information which may help in stratifying you for treatment options in the future. The one time when we try and avoid biopsy is if we are planning for treatments such as liver transplantation, and then we try to make the diagnosis on imaging alone if it is possible. The other contexts in which liver cancer is diagnosed is either accidentally, so you're being investigated for some other problem, and then almost accidentally the liver is noted to be abnormal and there's noted to be a lump within it, a lump or abnormality within it, which is then further characterized with CT or MRI scan. And lastly, if you present with symptoms as a consequence of the cancer, or symptoms as a consequence of the cancer causing the liver to either fail or have poorer function than we would expect. And unfortunately, under these circumstances, the cancer is usually more advanced than it would be than if it was diagnosed in surveillance. After the diagnosis has been made, your case and your scans will be discussed at what's called a specialist multidisciplinary team meeting. This is a meeting of all the professionals who will potentially be involved in your management in the future. It will typically include a hepatologist, a liver specialist doctor, an oncologist, a cancer specialist doctor, a surgeon, a hepatobiliary surgeon, a surgeon with expertise in managing surgical conditions of the liver, a radiologist, an X-ray doctor, including interventional radiologists, X-ray doctors who perform specific treatments for the liver cancer, and also, very importantly, bringing us all together, the clinical nurse specialist, who will often be the glue that combines everything together in your ongoing management, and specialists in supportive or palliative care. After your case has been discussed, and typically this will be with information that's been provided by your referring doctor with regards to your underlying liver tests and how the cancer has been diagnosed, you will be seen in a specialist liver cancer clinic when all those various medical disciplines, will be represented. In that clinic, we will assess you and try and stratify you for the best possible treatment. And there are three key issues we need to further investigate to understand what the best treatment for you is going to be. The first is understanding the stage of the cancer. How large is the cancer within the liver? Has it spread to involve the blood vessels? Has it spread outside the liver? The second key issue is how well is your liver functioning? In general, if your liver is functioning well, there are many treatment options, but if the liver function is impaired, our treatment options are much less restricted. The third key factor is how fit you are. You need to have a certain level of fitness to not only be able to tolerate anti-cancer treatments, but also to benefit from them as well. And this leads me on to passing the mic to Rohini, who is going to talk to you about the various treatment options we have available. Thank you, Rohini.
Thanks so much, Abid, for that really good summary about surveillance and the importance of surveillance, leading us on to the management of liver cancer. I think one of the key take-home points from what Abid was saying are those three factors that we look at in terms of trying to work out the best treatment for an individual person. So just to recap again, it's how far the cancer has spread. So is it involving any of the big blood vessels? Is it outside of the liver? If it's in the liver, how big is it? Or how small is it, in contrary to that? And how fit a person is. So someone might have a very small cancer, but they might have lots of other problems, which means that they might not be able to have treatment. And again, the most important thing is how well the liver is actually functioning. That's actually a really critical factor. The idea of having a multidisciplinary clinic, so a clinic where you have lots of specialists working together, is that everyone works together to make sure an individual patient is looked after both from their liver point of view as well as from their cancer point of view. And in that specialist clinic is also this clinical nurse specialist, who is probably the most important part of that team, because they're the liaison between the different medical teams, the surgical team, and with the individual patient. In terms of the different treatments that are available for liver cancer, they can be broadly divided into curative treatments, so treatments where we're aiming to get rid of the cancer in the long term, or what we call palliative or non-curative treatments. And what I mean by that is that's when we cannot get rid of the cancer, but we're trying to slow the growth of the cancer down to allow someone to live for as long as possible with the best quality of life. In terms of curative treatments, there's a number of different types of treatments. Sometimes people can undergo something called a liver transplant, and in that, the patient's old liver is removed and a new liver is put in. To be suitable to have a liver transplant, you have to have only a small number of tumours and an underlying liver condition. I'm not a liver transplant expert, so if there are any questions about that moving forward, I'm quite sure Abid will be happy to answer those in the question and answer session. Other types of curative treatments are things such as ablation or surgery. In ablation, what happens is if it's a very small cancer, we can put tiny needles on each side of the cancer and run an electric current through between those needles, and essentially we burn the cancer. There's other ways to also deliver that sort of ablation. So you can use something called microwave ablation, where you use alternating current again, or you can also inject the tumour with cold water, with ethanol. So you get lots of different ways of actually trying to burn the cancer. There's also some newer ways of doing it, which some centres have and other centres don't have, and it's called IRE, and these involve multiple different needles being placed around the tumour type, and again sending currents around those tumours. But the aim of ablation is essentially to burn the tumour away. The other option is something called surgery, and this is often done in collaboration with the surgeons, of course, and with the hepatologists. And again, you're looking to make sure that if you do have an operation, the rest of the liver is still working well enough to be able, so the patient can live normally afterwards. Even if a patient has had an ablation or has had surgery, we do know there is a chance that a new cancer could come up again. And this is because we know the underlying liver has been damaged. So people that have cirrhosis have the underlying liver damage, and there's always a chance a new cancer might come back. So even though a person might have a curative treatment with ablation or surgery, they still need to have a scan done. And we normally do it every 3 months to try and pick up if a new cancer comes up again. And again, the reason for this is to try and pick up a cancer early enough so that it can be cured. the chances of a new cancer coming back, even after having surgery or ablation, is around 30%. So it's quite high. And so we do need to keep a very close eye on patients. In terms of non-curative treatments, there are lots of different types. Sometimes people can use radiation treatment. So it's like having X-ray treatment, where a very fine focused beam of X-rays is pointed directly to the cancer through a machine, and again tries to burn the cancer. We can use something called transarterial chemoembolization, or TACE or TAE. And what that involves is it involves selectively putting a very fine tube into the blood vessel that actually goes and supplies the cancer, and either putting some chemotherapy inside, or some centers don't use chemotherapy, and then blocking off the blood supply to the cancer so the cancer doesn't get any more food and oxygen and it slowly dies. There's a new treatment that's just recently been approved by NICE, which is called cert, and this is selective internal radiation. So instead of putting in chemotherapy, we can inject tiny beads, which are probably the width of your hair, into the cancer, and these tiny beads are coated with radiation. The radioactive beads get stuck in the cancer and then burn the cancer from the inside out. So these are other treatments which can be used in patients in the non-curative setting. For patients that aren't suitable for TACE or cert, we then talk about what we call systemic therapies. And these are treatments which are either injected into the back of the hand or are taken as tablets. These are normally given to patients that have lots of spots of cancer in their liver, or if the cancer is in a very difficult position where we're unable to deliver any of those other treatments. They also can be given if the patient's cancer has spread outside the liver, so if it's spread to the lungs or to the bones, for example. The types of treatment that are available, as I said, are either intravenous treatments or tablets treatments. The intravenous treatments are relatively new and have only been approved by NICE last year. It involves the infusions of 2 drugs into the back of the vein, in the back of your hand. One of the drugs is a new type of drug called immunotherapy. The way immunotherapy works is it tries to stimulate your body's natural fighting mechanism to see the cancer and to try and attack it. It's combined with another medication called bevacizumab, which is a type of drug which actually targets the blood vessels. So in combination, not only are we stimulating your immune system to try and fight the cancer, but we also try and reduce the blood supply to the cancer so they doesn't get any food or oxygen. If you're not suitable for the intravenous treatments, then your doctor might offer tablet forms of treatments, and there are a number of different tablet forms of treatments. All the tablets essentially work in the same way. They all essentially target the blood vessels. So again, the idea is to stop the cancer from getting food and oxygen and slowly starve it. Some of the tablets will shrink the cancer down to a greater extent than the others, but essentially the tablets have exactly the same outcomes. All these medications, however, do have side effects, and I won't go into them, but they're quite extensive, and they're important things to consider if you are thinking, or if your doctor has spoken to you about having these types of treatments. As I said right at the start, quality of life is a really important factor, and so side effects are really important, and these will really impact on how a patient feels long term. And so often someone might have a good response on the scan from these tablets, but they might be having very bad side effects, and the doctor might suggest that we reduce the drugs or have a treatment break. And it's because long term we want people to be as well as possible for as long as possible. Some people, however, are not suitable for any treatment. And in this situation, we often work with people in the palliative care community. These are doctors and nurses who are experts in supporting people through their final journey. And these will be people who can help with pain relief. They can help with problems from liver failure. And it's really important that we all work together. certainly in our institution, and I'm sure it's the same in lots of other centres, we involve palliative care right at the very start so that patients and their families get to know the entire team, not just at a point where there are no other treatment options. So I think it's really important that you meet the palliative care team right at the start of the treatment journey if that's what an individual would like. So I'm going to leave it at that point because I know we've got a CNS who's probably going to speak a little bit more about patient support through their treatment journey as well. And I'm just a bit mindful of the time. So I'm more than happy to take any questions.
Thanks so much, Rahini. Thanks to both you and Abid for that insight. I mean, that's a fantastic way of starting us off and giving us the sort of pretty much the complete picture about what's going on, how things are detected, surveyed, and how the treatment options are discussed. We've already had some great questions come in, so please do, if you've got questions, please pop them into the Q&A box. And what we'll do is we'll get to those at the end of the presentation session so we can sort of group them appropriately. But what I'd like to do now is introduce Sarah Selimani, and I think both Abid and Rahini were fantastic in highlighting, you know, just how crucial the role of the nurse specialist is as part of the care team. And I'm really, really pleased that we've got Sarah here today to talk to us because, you know, the nurse specialist angle is so important in this journey and how a patient is looked after. So thank you, Sarah, for joining us, and we'll hand over to you.
Thanks, Jonathan, for inviting me. Thanks, Abid and Rahini, for that great talk. It was really, really detailed and good for people to see what's involved with all that people go through at diagnosis and beyond. So I'm Sarah. I'm a specialist nurse in HCC based at King's in London, and I see patients throughout their journey with HCC. So we support patients at diagnosis, through investigations, when they're having the different types of treatments and beyond. We provide support through the phone, in the clinic, on the wards, in the chemo unit, throughout wherever they are. We will see patients and support them. I think it's useful to talk about, you know, what that means. So what can you expect from your CNS? What's their role? And I think it can be quite vast, really. It's about a contact. So having something that you're not sure about and need someone to talk to about, you can call your CNS. Coordinating things. So if you're living quite far away from the hospital, how can we coordinate to make sure we can get scans done appropriately, quickly at a time when you can? Also, how we can coordinate other things along your pathway. But thinking more than just the cancer, so thinking about how we can assess all your cancer needs. And most CNSs at the time of diagnosis and beyond should be able to go through a checklist of symptoms and side effects you may have, which is a holistic needs assessment. That assessment is looking at all of your cancer needs, but also all of your needs and what we can do to help support you. So obviously, cancer in itself, cancer treatment has lots of side effects in terms of how you are feeling, being able to work, support that we need to give you, and the effects on you and your family. So coordinating those investigations and providing the support, being a resource for information. So we don't know everything, but we do have access to the doctors and can get support and advice from them and be able to give that to you. So I think those are sort of the broad part of what we're providing, and we will have seen lots of patients who are going through it and how we can support and give you information about what to expect. Because I think the first thing which people can find really difficult around diagnosis is not knowing anything like that, and that's where the British Liver Trust is a great resource to give that information, and what happens next. And sometimes waiting can be really difficult and not knowing, is something okay? Is it not okay? Something's new, you're worried about and you want to get some advice. So that's where the CNS can help. The first clinic appointment can be really overwhelming. You're having lots of information and you may not know very little before you attend. Some things which can be really useful are thinking about making a list of questions you have, keeping notes that you may think may be useful, and that there are no silly questions. So, you know, if you think the question may be silly, ask it anyway, because lots of other people will have thought, I really want to know that, and then I'm not. And I'll have patients who have their consultation. They come and see me and I say, is there anything else? And they say, oh, no. And then they get home and they phone me the next day and say, actually, I really wanted to ask this, but I thought maybe it was a little bit silly. But there are no silly questions. And, you know, about thinking about practical things. So practical things that we can help to support you with in terms of admissions to hospital or needing to come to hospital, transport and prescription costs and those sorts of things. We can help, but also linking in with local support. And I think it's really interesting and really useful with Rahini saying about palliative care. So palliative care are a great resource. So they are experts at managing side effects and symptoms of people with diseases that we can't cure and helping to optimize symptoms. So they do work throughout the pathway of patient care. So they work when people are less well, but also supporting people earlier in the pathway is shown to be really effective in terms of to help. And I think people find palliative care really a scary word. But those experts in that field of symptom management are really a great resource to think about. Another thing which the CNSs can help and do help with are around if you're feeling less well. So patients having treatment and feeling more unwell, not knowing, is this expected, is this not expected? The CNS can help you with that information, and also working closely with local hospitals, local referrers in terms of coordinating pathways if people are less well and needing more urgent care locally or in their cancer centre. But I think, yeah, so I think it's really useful to use your CNS. You know, we're here to be able to support you and to provide information, and also, you know, help link you in with the other support services that are available. I hope that was helpful. Thanks, Jonathan.
Thanks so much, Sarah. You know, again, it's really good to hear that piece of the jigsaw and how it all fits together. So thank you so much for coming along and doing that for us today. The final speaker we've got today, before we move on to the Q&A session, brings that really crucial component of the patient voice. I think it's really important, all the work that we do at the British Liver Trust, you know, be it, you know, supporting patients, talking to Parliament, talking to those in charge of healthcare, looking at submissions for new treatment, all of these things, when we're talking to the press. The difference in how we make an impact is when we have the patient voice alongside us to be able to explain, you know, firsthand what it means, how it works, the impact it has on them. So it's really crucial that we have that, but we know it's not always the easiest thing for people to stand up and talk about their own experiences. It can be quite daunting. Obviously, it's often quite personal. But I think both to Monica directly today and to everyone who does support us by sharing their story, it's a huge thank you, because it means that the work that we can do on behalf of patients is so much more powerful. So Monica, thank you for joining us today. I'm going to hand over to you to have your little chat with us about your particular journey. Thank you.
Hello. For those who I haven't already met, albeit virtually, my name is Monica, and I was diagnosed with primary liver cancer on my actual 61st birthday. I mentioned the actual date because I think obviously it's a date that I will never forget, but by then I'd already known that there were some problems with my liver, but it was still a bolt out of the blue to get the cancer diagnosis. Luckily enough, I had my sister with me as she was actually treating me to a birthday lunch. And up until then, we thought I was just attending a follow-up appointment to check on the progress of my liver, which up until then had shown slight signs of hardening. I don't want to make light of my diagnosis by any means, but we still went to lunch. Because apart from the shock of hearing the word cancer, I don't think either of us could, or we didn't want to take it in that this is the stage we'd now reached. Although in theory that was the start of my cancer journey, excuse me, which ultimately led to a transplant a few months later, unknowingly my journey had actually started in my early 30s, when our mother died suddenly of liver failure at the age of 62. Her actual cancer diagnosis came far too late for any form of treatment. I only mention this to re-emphasise Dr. Suttle's earlier points of early diagnosis and screening, which obviously for our mum was not available at that time. Subsequent to her death, we learnt she had unwittingly passed hepatitis B onto me at birth. The advice given to me at the time was I was actually still a youngish woman, and I was outwardly fit and well, and this wouldn't be a serious problem for either myself or my children, other than they should be vaccinated against it, which they both were. Fast forward to when I'd just turned 60, I had started to feel slightly out of sorts, and even to this day, I can't really describe what it was because it was nothing specific. I delayed seeking medical advice because I made one of the biggest mistakes some of us do make. I decided to self-diagnose myself. And I thought that this could be the beginning of what ladies of my age start to go through. And then it wasn't until I'd noticed that my hair was falling out more than usual. And in a way, it was my vanity that made me go to my own GP. This visit, it started a series of blood tests, even a scalp biopsy, which it really hurt and obviously turned out to be unnecessary, some gastro procedures, an ultrasound, and an appointment with a gastroenterologist and a hepatologist, at my local hospital. The net result of these tests and so on was that there was some slight anomalies in my blood, and there was just the beginnings of some scarring on my liver. It was then, at that point, because of my family history, it was decided to refer me to King's College. Even at this point, I didn't equate how I was actually feeling with how ill our mum was prior to her passing away. Once I had my first appointment at King's, it was virtually textbook to what Dr. Suttle had described earlier. I went through all of those procedures he described, accumulating in a final MRI scan with the dye. Can't quite remember what it was called, but that actually revealed a tiny tumour the size of a thumbnail on my liver. By now, I was under the care of the liver unit, and that's when I first met Dr. Suttle. And incidentally, neither of us knew until a few days ago that we were going to be on this panel together. But hopefully, in a good way, I hope, you can see I'm almost one of his before and after patients. Although my tumour was tiny and not fast growing, because of its position, it was decided a portal vein embolization was my best option at this point. Once the surgery had started, it was quickly realised that my liver was actually far too cirrhotic, and now my only option was a transplant. Even though I hadn't really shown outward signs, and again, going back to Dr. Suttle's points, you don't necessarily present with all the symptoms that you could maybe associate with liver cancer. But there I was now at the transplant stage. And to be honest, from now on, I was just a passenger. And all I could think about were the effects on my husband, my children, and also my brother and my sister, both of whom had witnessed our mum passing away. Even worse was the fact that I was now exactly the same age as my mum when she died. This particular period, looking back, it's something that I've reflected on after everything that happened. I wish in a way I'd been made more aware, or I'd taken more notice of the support that could have been there for my family. Because in a way, everything that was happening to me. And as I said, felt a bit like a passenger, but it was also happening to them and affecting them in ways that I could never even imagine. And really and truly, sometimes I've stopped to think myself, did I actually ask how it was affecting them? Because everything was focused on me. In particular, my sister, because she had been with me from the day of diagnosis. she continued to come with me to all the pre-appointments and so on. And she was fantastic. And I was very lucky to have somebody with me, because in a way, going back to what Sarah said, yes, I was going through all these tests, and I was being told this and I was being told that. If I'm honest, I wasn't really taking it in. It was going in there and out there. But my sister was there, and she was the calmer of the two. She would then disseminate the information to my husband and my children, because they were far too almost emotional over it. So that's one thing, looking back, about extra support for family and friends who are going through this journey with you. That's as for my transplant, it all happened so quickly that I do sometimes have to remind myself it actually did happen. And again, I don't wish to make light of the whole my whole situation, but after being listed, I got my call 13 days later. I arrived at King's by 1 p.m. that day. I actually had the transplant by 8 p.m. that evening, and I was onto the recovery ward by 5 p.m. the following day. There I was thinking, what's just happened? Again, it was just almost bizarre, surreal, I think is the best description I can give you. Very lucky, I recovered very well and very quickly. I was discharged 12 days later, and that was nearly 5 years ago now. My recovery couldn't have gone better. So much so that within 9 months, I was on an aeroplane with Dr. Suttle's permission, I hasten to add, with my sister again. And we were going to New York for a shopping trip, which, looking back now, if somebody had given me that timescale from my diagnosis, I would have thought, there's no way, it's crazy, crazy. Also, I'm shortly going for my 5-year scan and crossing everything. Assuming it's clear, which it has been since I've had my scans, first 6 monthly and then annually, I could be termed cancer-free. So that's really my story in a nutshell. But after listening to Dr. Suttle and Sarah, cannot overemphasize the importance of the early diagnosis. And if you feel something's not quite right, you're your best judge of your own body. Just please don't delay. Do not delay getting some medical advice or help. Also, to say to you all, as frightening as a cancer diagnosis is, which it really is as soon as you hear the word cancer, it really doesn't have to have the worst outcome. The other thing to say, really, I've tried very hard from day one. I've tried to stay positive. It was hard at times, it really was, but I firmly believe that this is what has seen me through this entire journey. And here I am being able to tell you my story. And that's me.
Monica, thank you so much for that. I think inspiring, obviously, to all of us listening to that. And I think it's wonderful with you talking about, the importance of friends, family, carers who are on that journey with you as well. And that's something I think cannot be underestimated. So
I think my sister has even joined us today.
Oh, fantastic. That's brilliant. So, well, all credit to her as well. That's amazing to hear that story. And I think there's so much there that, you've just said, which is invaluable advice to people who are going through similar situations to what you went through. And as I said before when I introduced you, having that direct patient voice is so crucial. So thank you very much for being with us today and for putting that forward. It was amazing. There's just your sister has just posted on the chat. So, that's brilliant. Thank you so much. That's wonderful. Thank you. If I could ask the other panelists to rejoin us, switch the video back on and come back on with sound. That's amazing. Thank you to all of you. I mean, what an amazing sort of set of information to run through in such a short space of time. So thank you for all the hard work you've put into to bring all that information to us today. Not surprisingly, that's given rise to many questions. So I'll start working the way through those. So the first one goes sort of right back to some of the detail you were talking about, Abid, at the start. So alpha-fetoprotein, is that always raised in levels at the later stages of liver cancer? Because one of the patients who's with us today had liver cancer for 3 years, but had never had a higher level than 2. So just any insight you've got into how the levels work would be really useful.
Yeah, so the short answer is no, it's not always elevated. The alpha fetoprotein is a blood test which is associated with the more advanced stages of liver cancer. So the higher the level in general, the more advanced the cancer is. But you can certainly have a more advanced cancer with a negative alpha fetoprotein. So it's a kind of blood test which, if it's positive, provides an extra bit of information. But if it's negative, it certainly doesn't exclude the possibility of liver cancer and doesn't even exclude the possibility of later stages of liver cancer.
Okay. Fantastic, thank you. I'm going to move straight on to one which is probably one that everyone can chip into, and I think it's really crucial and something we hear so much about. Early detection clearly is something that we all want to see improved at every possible opportunity. We at the Trust have actually done a lot of work recently about looking at pathways within primary care and what's happening with the primary care sector about liver disease in general. But do you think there are things that can be done that will help GPs understand the risk factors earlier and could potentially help them highlight those who are at risk earlier and obviously get them into treatment options sooner? Are there things that could be done around that area? Do
you want me to take that on to start with, or anyone else? Or I could. Do
you want to start us off, Abby?
Yeah.
And then maybe, yeah.
So I think this is the absolutely key issue. It's liver disease can be asymptomatic in its early and even in its later stages, and identifying those who are at risk of liver disease at an early stage to firstly prevent them developing cirrhosis, and if they've developed cirrhosis, to then provide optimal surveillance for cancer is absolutely key. And this is why the work you and the British Liver Trust are doing is so important. It's about education, it's about developing pathways, it's about screening on a population-wide basis, but specifically focusing on people who have potential risk factors, such as those who drink too much alcohol, those who have risk factors for fatty liver disease, identifying viral hepatitis at an early stage. All these factors are absolutely key.
Sarah, Rohini, did you want anything to add anything to that?
Just to say, Jonathan, there's a lot of initiatives. I think there's quite a good initiative up in northern London with the Royal Free Hospital, all the surrounding primary care networks there, where they're doing a lot of education. They're also built a whole framework where general practitioners can refer patients in if they've got an elevated FIB4 test, which is a combination of blood tests. We're about to start doing some work in northwest London, again, trying to help general practitioners with that pathway and also providing education. So I think there are a lot of really exciting initiatives going around the UK. And I think that what it's going to be a matter of is trying to bring them all together in a framework that works effectively for the different general practitioners in the different areas of the UK.
I agree, and also thinking about specialist HCC services, sharing the knowledge within those centres and working together to collate those things together.
Fantastic, thank you. We've got a particular question around CERT and a query about its availability nationally. So are there areas of the country where it is or isn't available? Is it something that's available to all? Where do we stand with that at the moment?
So currently CERT is only available in certain centres. This is a historical point, and those centres were decided early 2000s. There is a move right now to get more centres on board, particularly as NICE has just approved CERT for hepatocellular carcinoma. So there are more centres that are currently being commissioned by the NHS. The MDT, however, if you're not from a CERT centre, the MDT hopefully is discussing CERT, and certainly different MDTs can refer to CERT centres, so patients shouldn't be disadvantaged because their centre is not a CERT centre. So, for example, Imperial's not a CERT centre, and we refer our patients to the Royal Free Hospital. So there's a lot of conversation and a lot of work between the different centres.
Fantastic, thank you. Sarah, we had a question, particularly, I think, inspired obviously by what you were saying about, the nurse specialists and the importance of that. Is it routine that every liver cancer patient should have a nurse specialist? So if that sort of should be the default now, or?
Yeah, so I think the default should be that everyone has access to a CNS. It may be that they're not HCC specific, so they may have an upper GI CNS or an HPB CNS, but actually they will be able to provide similar resources around navigating the pathway and support around their cancer care.
Okay, and if anyone's worried that they're not getting maybe the support they think they should be getting, what would be the advice in that situation?
To contact their clinical team. Sometimes some patients who are maybe having immunotherapy, their link nurse may be someone in the chemotherapy unit. So they may have slightly different names, but I would contact the clinical team if they feel they're not having that support, because a key part of their journey, of the patient journey.
Fantastic, thank you. Monica, we had a question come in regarding support for families and carers. I think this would be one that we could maybe get your thoughts on. So, obviously you talked about the support you got from your family, but I think it's also important about the support that exists for families and carers who are supporting patients through their journey. What did you find was valuable to people surrounding you, and what were the important things like that?
Well, in one way, I'm guessing it was because I think everything happened so quickly for me. We were not aware at the time of any easily available support. I think because everybody was focused on me, not really thinking about themselves. And if anything, when I was starting to be told all the different stages and so on, if I had been told, I don't know if this makes sense, if I'd been told, well, look, your family could go here, your family could perhaps have access to such and such a nurse. Yes, it's all well and good telling the family members, but I think I would prefer to have been, as the patient, I would have preferred to be told, look, this is where your family could possibly get some help, if that makes sense.
Yeah, thank you. It's such a crucial thing, isn't it? Because it's they're an extension of what you're going through, and there's just as much need for them to have a space to find that information, and sometimes just to unload completely differently in a different way to maybe you would. So
yeah. Post-transplant, it was great. I had a lovely coordinator, Sarah. If Karen's in, you can say hi to her for me. And I mean, she was brilliant with everything on all aspects. But pre-transplant, again, whether it was because it happened so quickly, I was not aware of a nurse specialist being assigned to me.
Okay, thank you. We've got a couple of sort of just, hopefully we can just rattle through a couple more. Question coming about transplant, and I think we sort of briefly alluded to part of this answer, but sort of when somebody's gone through and had a liver transplant, what are the factors that indicate whether the cancer may or may not return, or is there a sort of an expectation for certain conditions that a transplant should basically solve the issue and some not, or is there anything you can shed light on for that for us?
So we hope transplant will be a curative treatment, both for the cancer and the underlying cirrhosis, which is a risk factor for further cancers developing. So that's why we're so passionate about transplantation for this condition, because well, you look at Monica 5 years post-transplant and you think that's a great advertisement for what transplantation can do. Now, there are quite rigid criteria for transplantation, and when the liver is removed, we'll examine it in detail, and there are some factors which are associated with a risk of the cancer returning. But in general, it should occur in less than 15% of cases.
Thank you. Question about TACE. Somebody's asked whether it's normal to feel tired both before and especially after TACE. Is that a commonly occurring sort of symptom? Feedback on that?
Yes, I didn't go through all the side effects of everything because we would be here for quite a long time having those conversations. TACE is pretty tough treatment because you're suddenly blocking off the blood supply to the cancer. It doesn't like it, and it starts to almost react, and patients will get what we say, they'll get a release of all these inflammatory markers into their bloodstream. Some people can feel very tired and run down up to even 2 weeks after having the taste. Other people can get nausea and vomiting. It can also cause the liver not to function properly for a very short period of time. So it is pretty tough treatment, and we would expect people to feel quite tired after the taste.
Thank you. And maybe I think time for one more, if I could just get that in before I do the sort of the wrap up. We've had a question about how quickly patients are being seen at the moment by oncology services for cancer. I know there's been a lot in the media about potential delays as a knock-on of the pandemic. So any insight or commentary on that?
So we have to stick to our targets. So once a patient is referred, they have to be seen within a period of time. Certainly for our MDT at Imperial, patients are seen within a fortnight of being referred, and I'm sure it's the same at King's as well. We try and see patients with cancer as soon as possible.
That's exactly right. That we will see people pretty much as soon as we've discussed their scans in an MDT. What I would say is that some surveillance was missed during the worst of the coronavirus pandemic, during the 2 surges of the coronavirus pandemic. For understandable reasons, ultrasound scans were missed. Please make sure, if it's appropriate, you get back onto that surveillance schedule. Please contact whoever is supervising your liver care to make sure you're back having the 6-monthly ultrasound scans.
Thank you. I'm sure it's good, reassuring to hear that that's what's happening. I know that there's probably a few mixed pictures across the country, but hopefully things will get back to as close to those targets as possible as soon as possible. But great advice, thank you. I can't believe how much we've actually managed to get through in an hour there. It's phenomenal. Thank you all so much for taking us through that in such clarity and such detail at the same time. So we're very grateful. The event will be posted up onto our website and our YouTube channel in due course. So obviously anybody who wants to go back and have a look and hear some of the items again, you're more than welcome to. And equally, if you know people who would benefit from having a look at some of the information on here who weren't able to attend today, please do feel free to share it around. I think one of my colleagues has posted in the Q&A or the chat below, but please do remember that as well as the fantastic support that we know that patients get from their clinical teams, the British Liver Trust are here to provide additional support in other ways. So we've got our nurse-led helpline, we've got a number of publications and resources for patients. Our patient support groups are particularly popular, and I know how important they've been, particularly during the pandemic, to connecting people facing the same sorts of challenges. So lots and lots of information on our website, and we will be sending out a follow-up to everybody who's attended this event, which summarising all the information and resources that we've talked about. So you'll have the signposting to that. But as I say, in the meantime, if there's anything you want to look at quickly, please head over to the website and have a look at that. I think just all that remains me to do is really just thank everybody again, both the speakers for their fantastic input, and also all of the people who've joined us today to talk about what is such a critical subject. So we will continue to work alongside clinicians, alongside patients to move things forward. And it's, I think, a reminder today. We've heard an amazing amount of detail, but also some reminders of the positive stories that are out there, and I think some amazing advice that will hopefully make a real difference to people on their journey. So thank you, everybody. We're very grateful.